Hello, everyone, and welcome to the Sarcoma Foundation of America's panel discussion on desmoid tumors. My name is Christy Arishton, and I am the Program Manager for Engagement and Research at SFA. Thank you for taking the time to join us for what promises to be a very interesting session. Before we begin, I'd like to briefly go over the format and the logistical details of this webinar. I will be serving as the moderator for today's session. We have three panelists, as well as Lynn Hernandez, who will also be helping me moderate this session. They will provide an introduction to desmoid tumors, in particular the consensus initiative from the Desmoid Tumor Working Group, and a patient representative who will be sharing his story. After their presentation, we will open up to a questions and answer session. SFA moderators, myself and also Lynn as well, will pose questions submitted to our panelists. At any time during today's session, you can submit your questions by entering them in the questions field at the bottom of your screen. Our panelists will not be able to answer questions related to your specific medical situation, so please make sure that they are related to the topics raised during the session. The information in this webinar is for educational purposes only, and make sure that it is not a substitute for medical advice from your physician about your specific situation. So make sure that all of your questions are general and not specific to your unique case. Today's session will be recorded and a link will be posted to SFA's website. And finally, as a reminder, all participants are muted. So please remember to use the question and answer box. Okay, so now I would like to introduce our panel members. First, we have Dr. Gounder. Dr. Gounder is the Scientific Director of DTRF and a member of the Medical and Scientific Advisory Board. He is a medical oncologist at Memorial Sloan Kettering Cancer Center, specializing in sarcomas and developing new drugs in cancer and desmoid tumors. He is an internationally recognized leader in desmoid tumors and has led multiple clinical trials in desmoid tumors. He led the phase 3 international study of sorafenib, and I'm sorry, I'm never going to be able to pronounce the new drug that just came out in desmoid tumors, in collaboration with DTRF, MSK, and IQVIA. He developed the Goddess patient-reported outcomes tool and the first of its kind to evaluate the experience of patients with desmoid tumors. Dr. Kasper works at the sarcoma unit at the Mannheim Cancer Center, University of Heidelberg. He has a lifetime professional dedication to patient care and research in soft tissue sarcomas, desmoid-type fibromatosis, and gastrointestinal stromal tumors. He is head of the study center of the German Interdisciplinary Sarcoma Group. He serves as the current chair of the EORTC Soft Tissue and Bone Sarcoma Group and is a member of the board of directors of the Connective Tissue Oncology Society. Dr. Kasper is also a board member of the DTRF. And finally, we have Lynn. Lynn is the executive director of DTRF. She has been directing DTRF's 5K since 2012, and her work experience spans multiple sectors and industries, including the federal government, retail, .com, large nonprofits, and small business. While she has acquired a significant, extensive skill set from these experiences, she has been known to say that they pale in comparison to the depth and satisfaction she receives through her work with the DTRF. We are very appreciative to have Lynn and the DTRF partnering with us on this presentation today. So Lynn, please feel free to introduce yourself and DTRF and Chad.
Oh, wonderful. Thank you so much, Christiane. It's wonderful to be here today. So the Desmoid Tumor Research Foundation was founded back in 2005 by a desmoid tumor patient and caregiver. Ultimately, our mission is to find a cure for each and every patient facing desmoid tumors. We fund research, we accelerate the development of improved therapies, we drive collaborations between scientists and clinicians, and we provide education for the community at large. The foundation is a convener for all stakeholders in the space. And over the nearly 20 years since our founding, we've built an international community of scientists, clinicians, and patients, most importantly, around research and clinical management. We were a key player in the development of the first approved therapy for desmoid tumors just last year, November 2023. And I would like to share a few resources, which can all be found on dtrf.org. I mean, obviously, you can find a wealth of information about the disease, including information about diagnosis, treatment, and monitoring, We have disease-specific treatment guidelines entitled the Global Consensus Paper on Desmoid Tumor Management, which Dr. Bernd Casper will speak to today, and also information on our grant funding. Over the years, we've funded research globally at top institutions like Stanford and MIT. Patients and caregivers can find information on virtual and in-person educational and networking events. And they can also find ways to engage with us by contributing to research efforts, by sharing their journey, and also by fundraising to support our mission. It's wonderful to be here today, and I'm really, really thrilled to introduce Chad, who was diagnosed with a desmoid tumor in 2009 and is still living with a few desmoid tumors. They have defined his life, but they do not limit him. He views desmoid tumors as an accelerator for self-development and perseverance. He recently attended Carnegie Mellon University, where he competed in varsity football and track and field. He is currently working for a nonprofit advocacy group, and he is pursuing a career in law. Chad, we'd love to hear a little bit about your experience with desmoid tumors.
Thank you, Lynn. So my name's Chad Guzzi. I live outside of Philadelphia, and like Lynn mentioned, I've been a patient since 2009. So it's been 15 years now. Starting out, in the beginning of the journey was it was kind of like I didn't really know what was going on, really. I was so young that I was just went along with what was going on. So I was on a bunch of chemotherapies, and I don't really even remember the names. At the time, I didn't even know what it was really, but I was seen in Philly. And my perspective, I feel like, is a little bit unique because I was an athlete throughout the whole time. So there were times when I was getting my treatment, and then that same day going and playing in a football game. So that was it was definitely challenging because the treatment at that age made me feel really sick, and it was it was tough having to go the morning getting my treatment, and then later that afternoon playing in a game. It was tricky. So I was I would say most of my childhood I was on different types of chemotherapies. They really weren't doing all that much, to be honest. It wasn't really slowing down the growth, or it wasn't shrinking it or anything. And then fast forward, I kind of kept through with that route. And I managed. I did pretty good at sports. I played football and track and field at CMU. And then so recently, I had to get a bunch of surgeries that were pretty intensive. So I spent 3 months in and out of the hospital just last year, where I was bedridden, and I couldn't really walk around because my which I probably should mention this before, my tumor location is in my foot and my thigh. So I spent a lot of time with my leg propped up in a bed for 3 months. So that was not the greatest. But the good news is that recently, with the new treatments that are out, I've seen a lot of improvement, and I've recovered from those surgeries that I had a year ago, and things are going great. I've actually, for the first time in my life, I've seen significant decrease in the tumor growth, which was awesome news, and things are going well now.
That's great, Chad. Thank you.
Can I ask you a question?
Yes.
So are you actually on one of the new therapies now, or?
Yes.
Okay.
Yes.
And so you are actually treated with nirogacestat, or yeah.
Yes.
And it works well.
Yes, it works for me. Yep.
Perfect.
thanks for being willing to share your experience with us, Chad. I'm sure there's plenty of other folks who have other questions for you. So we'll look forward to the question and answer session at the end as well.
Of course. Thank you.
Great. So at this time, I think we'll turn the floor over to Dr. Casper and Dr. Gounder and hear what you have to say about the Desmoid Tumor Working Group consensus. Going to share the screen so that you can see their slides, and we'll look forward to more questions at the end of the session.
Okay, thank you very much, Christy. Yes, I would actually like to start a bit presenting you the work which we did over more or less the last 10 years now, when we formed a group which we called the Desmoid Tumor Working Group. And I really want to emphasize and point out that this is an initiative which is not done by us as medical experts. It's actually a joint initiative together with the patients. And we started off this initiative 10 years ago together with Sarcoma Patient Advocacy Global Network, which is actually the patient organizations for sarcomas, desmoids, and GIST in Europe. And meanwhile, it's organized globally, and with the DTRF and also with the Italian Desmoid Patient Organization and the German one. So, Christy, if you go to the next slide, I mean, you all know that we are talking about a very rare disease. It's desmoid tumors are a monoclonal fibroblastic proliferation, which is characterized by a variable presentation. And clinically, it's often very difficult because the clinical cause can be very unpredictable. So the incidence is low. We have about 5 cases per 1 million of the population per year. And when we started this initiative now 10 years ago in 2014, the problem was that there was absolutely no phase 3 data. So we had no what we call level 1 or 2 evidence, so very high level papers or clinical studies which could actually draw some good results on this disease. So the problem was we only had case reports, very small series, no really prospectively conducted studies, and it was really difficult to come up with a guidance or a management strategy for these patients. So the initial idea was then to come together were medical experts at that time on the European level from the ERTC, which is a European organization for research and treatment of cancer, and with the European Patient Organization. That was the first meeting we had in 2014, and we came up with the first kind of position paper where we tried to put together some treatment recommendations for sporadic desmoid type fibromatosis, which was published in 2015. If you go to the next slide, we updated that in 2017, and the next one in 2018, we pushed the whole initiative forward within 2 aspects. First of all, we really had, or we performed a really consolidated literature search, which was done by an external institute here based in Germany. And the second thing, what was, I think, even more important, is that that the Desmoid Tumor Working Group went global. So we invited our colleagues from the US, from Canada, from Asia, and so the group became bigger and really became globally. If you go to the next slide, that was actually the initiative from 2018, and we published that first global consensus paper then in 2020 in the European Journal of Cancer. 5 years later, next slide, in 2023, it was definitely time for an update. I mean, meanwhile, we had, of course, the data from nirogacestat, from the gamma secretase inhibitors. There were more data out on local therapies, on sorafenib, and so on. And that was actually the workflow we went through. We started that all with a kickoff meeting in 2022. We then performed this literature search I already explained at the beginning of 2023. and of course divided the whole work in different smaller groups, such as writing groups, and drafted a paper which we then discussed at the consensus meeting, which took place in June last year in Milan, in Italy. And from that on, we worked on a publication which was actually the target of the whole initiative. Okay, the next slide is then going to, I mean, this was a one-day meeting, this consensus meeting in Milan. And of course, you cannot cover everything in such a small or in such a one-day meeting, but these were the topics we were actually discussing and talking about. We were talking about local therapies and their place in the treatment algorithm or treatment armamentarium in contrast to systemic therapies. We talked about systemic therapies, of course, and when choosing systemic therapies, is there a first line? We looked at surgery, radiotherapies. Are there still any indications for these kind of therapies? And what we also did this time, in comparison to the last one in 2018, we put a much greater focus on two specific patient populations, the pediatric patients and the FAP patients. So FAP patients means those desmoid tumor patients who have desmoids in conjunction with this FAP, with this familial adenomatosis polyposis. So we invited a lot of more experts and also more patients covering these two patient populations. We looked at quality of life, benefit, and we updated the overall treatment recommendations. So the next slide is, I will quickly go with you through the consensus statements now. We can, and I will focus a bit on the systemic therapies, because this is, of course, I'm a medical oncologist, and this is, of course, the topic which I'm most interested in. And it's also the topic where a lot of progress has been made over the last couple of years. But the first topic we talked about was these local therapies, and there is one local therapy which appears to be quite promising. This is cryoablation. There is actually one prospective study out from France, a study which is called CryoDesmo-1. And the indication in this study for cryoablation was a growing desmoid tumor after at least 2 or more lines of medical therapy or functional symptoms of pain. Of course, a multidisciplinary discussion is important here, and you always have to keep in mind that cryotherapy is, of course, not available in every center, in every country, and requires a very specific interventional radiology expertise, and randomized trials are, of course, encouraged. When we go to the next slide, this is the slide focusing on the systemic therapies. Actually, I started my talk speaking about the phase 3 studies. I mean, a phase 3 study is actually the highest level of evidence. When you really perform a study, these are usually or very often placebo-controlled trials, and that was also the case in these two trials. And we only have these randomized phase 3 data for two compounds for desmoids, that is sorafenib, and most recently the gamma secretase inhibitor nirogacestat. And meanwhile, the second one, nirogacestat, is now also approved for desmoid tumors for this disease indication, and is therefore the first ever approved drug in this disease indication. If you go to the next slide, Christy, I will quickly present to you a bit of data about these two compounds. The first study that was already mentioned at the very beginning was actually led by my colleague Mirnal Gounder, the sorafenib trial. That was a placebo-controlled trial, which actually showed that sorafenib is superior to placebo, and was also published very prominently here in the New England Journal of Medicine. The next few slides are about, you can go to the next one, actually about the nirogacestat. So at some point, we found out that gamma secretase inhibitors, which is interestingly a drug which was initially used for a completely different disease 20, 30 years ago, gamma secretase inhibitors were developed or have been used for Alzheimer's disease. And more or less by chance, we found out that there was a kind of activity for desmoid tumors, and we performed at the end this phase 3 trial with this gamma secretase inhibitor called nirogacestat for progressing desmoid tumors. And as the principal investigator, I had the pleasure to present the data of this trial at the ESMO Congress in 2022 in a very large session in the plenary session there. If you go to the next slide, I just show you the kind of trial which we did. It was a phase 3 trial comparing this gamma secretase inhibitor nirogacestat versus placebo, a double-blind placebo-controlled trial which we ran in 37 sites in North America and Europe. 142 patients were all over randomized in this trial. We looked at different endpoints. The primary endpoint was progression-free survival, and we looked at a couple of secondary endpoints, such as response rate and a lot of patient-related endpoints, such as pain, symptom burden, physical role functioning, overall quality of life. The next slide shows the primary endpoint, and that was absolutely positive, of course. You do not often see Kaplan-Meier curves like that, but this clearly shows that nirogacestat reduced the risk of disease progression compared to placebo. Nirogacestat is the blue line and placebo is the black line, and it reduced the risk of disease progression by 71%, which is extremely high. So the median progression-free survival for the placebo group was around 15 months and was not even reached for nirogacestat because there were actually no events. If you go to the next slide, that shows the overall response rate, which we measured. That was 41% for nirogacestat and only 8% in the placebo arm, and there were 7% complete responses in the nirogacestat arm. What we also saw is that this drug obviously works quite fast, and the time to objective response was 5.6 months for the gamma secretase inhibitor and was almost doubled in the placebo arm with more than 11 months. So the next slide is a very important one, as it shows one of the secondary endpoints. The thing is that with this drug, we did not only reduce the size of the desmoid tumors, but what it actually did, and this is maybe for the patients even more important, is that we could reach a lot of improvements in terms of quality of life, symptom severity, pain reduction. And this is just one example to show that nirogacestat significantly reduced the desmoid tumor-specific symptom severity that was measured by a very specifically developed symptom score for desmoid tumors. And there are, of course, a couple of more of these kind of graphs, which I will not show here. The next slide. There are, of course, also some side effects. These are the most frequent side effects, such as diarrhea, nausea, fatigue, a low phosphate measurement, and rash. And these are actually the most frequent side effects. But on the other hand, 95% of all these side effects were grade 1 or 2, so rather low grade, and a lot of them usually occurred very early at the beginning of the disease or at the beginning of starting with this treatment during cycle 1. So usually during the first days or weeks of starting the treatment. The next slide. We published this study last year in the New England Journal of Medicine very prominently. And what is even more important, this trial and this publication at the end led to the approval of this drug. This is shown on the next slide. And in November last year, FDA approved the first therapy for desmoid tumors, and nirogacestat was actually approved for adult patients with progressing desmoid tumors who require systemic treatment. This is important to tell that it's only used, or it should be only used for patients with a progressive tumor. Okay, next one. If we go back now to the recommendations from the consensus initiative, I showed you now these two compounds where there is phase 3 data. However, we do not have comparative studies there. Therefore, it is not really possible to propose a definitive sequence of the systemic therapies we have. It was also mentioned that chemotherapies are used, and yes, we can also use chemotherapies. So we have a couple of different compounds and possibilities to use. And what we actually do is we look at the individual patient situation, we look at the toxicity of the individual agents, and then decide which to take. The richer the armamentarium is, the better it is at the end, because it allows us to have multiple choices for each clinical scenario. The duration of therapy is a very specific topic, but what we usually recommend is a duration of at least 6 months. The next slide now goes to the indications for surgery. Our patient reported that he underwent a couple of surgeries. That is actually something which completely changed over the last 10, 15 years. 15 years ago, 20 years ago, surgery was the mainstay in this disease, but that has actually changed completely. We usually do not recommend surgery anymore, but surgery does have a role when there are complications such as bleeding, obstruction, or perforation. Then surgical plays a critical role, but the goal then is usually not to receive or to achieve a complete resection of the tumor, because this may be associated with a lot of morbidity. So the goal here is just to treat the complication. And if we have a progression on medical treatment or active surveillance, then surgery may be discussed, but you always have to take into account the morbidity of the resection, and you should only do this when this is rather limited. The next slide is dedicated to radiotherapy, which doesn't have a major role in desmoid tumors anymore. If we do have a situation with a progressive or symptomatic disease and the patients are not candidates for systemic treatment, then we can think of local therapies, including radiation therapy, which may be a modality for desmoid tumors which are too large for cryoablation and for which surgery would be associated with unacceptable morbidity. And what is also important is that radiation is usually not indicated as an adjuvant treatment after surgery. The next slide, as I said, we dedicated much more room and space to two specific patient populations, and I just picked out one, the pediatric patients. In principle, the treatment recommendations for children are more or less the same. We usually start with an initial observation to really better understand the behavior of the desmoid tumors. Surgery, resection should be avoided. There is only a bit a difference in the kind of systemic therapies we use for children. Usually methotrexate vinblastine is the preferred regimen. An alternative option is a tyrosine kinase inhibitor, but we do not have very much data on tyrosine kinase inhibitors in children. There is also a study still ongoing for gamma secretase inhibitors in children, with the same one with nirogacestat, but we do not have the results yet, and so the use of these gamma secretase inhibitors in children should be delayed until we really have the results there. The next slide is quality of life and benefit. This is rather logical. I think that it is of course important to offer the patients an interdisciplinary supportive care, because this is a disease which can affect a lot of aspects of patients' life, their social interaction, their ability to work and relationships, but I'm sure we will hear more about that in the next couple of minutes. a collaborative and personalized management is very important here, which should include pain specialists, physiotherapists, psychologists, and social workers. Yeah, last but not least, the next slide. What we did, we developed treatment algorithms or treatment recommendations, flow charts, if you want to put it like that. And this is just an example to underline that for the majority of the patients, we usually start with what we call active surveillance as a frontline approach, that at the beginning, we really try to find out how the desmoid tumor behaves, and if there is really an aggressive growth and functional problems, symptoms, so on, we do think about a treatment indication for usually systemic therapies or other kind of therapies. And these treatment recommendations are also part of the publication. Next slide. This is actually the group with whom we met in Milan last year. We met in person with around 50 to 60 people, and we had a couple of people joining online. The whole desmoid tumor working group are almost 100 people now, and we put together a very extensive manuscript, which actually just came out today in JAMA Oncology, a couple of hours before we started the session. Next slide. And so we will certainly circulate that and make this available to the experts, to patients, and so on. Last slide is, I just want to say thank you for your attention. And if you go click one more, I especially want to thank Alex Cronky, with whom I'm pushing forward this initiative now for 10 years. He's a surgical colleague based in Milan. So thank you very much for your attention, and happy to take any questions, of course. Thank you.
Thank you so much. This was a lot of great and wonderful information, rich with lots of fodder to discuss. So I know we have several questions that are already open in the chat. But before we get started, Dr. Gounder, did you have anything in particular that you wanted to add before we open the floor for everyone?
No, not at all. First, thanks for inviting me. It's always a pleasure to be on these SFA educational programs. I learned a lot from my colleagues, as well as from the questions that the patients pose, and of course, patient experience themselves. I think Dr. Casper's overview was really extensive. I was thinking maybe we can jump into questions from the people who are joining, and we can use that as a free flow to just kind of educate and sort of dive deeper into certain things that are maybe confusing for people.
Yes, absolutely. That sounds wonderful. So there's actually been a few questions that have come through specifically about mutations, and if there are specific mutations that do or do not respond better or worse to the SpringWorks medication that has recently come out. FAP mutations and or CTNNB1 mutations. Is there any information known about mutation-specific response?
Yeah, there is actually. So first of all, we have to differentiate between these two groups. There are what we call the sporadic desmoid tumors, which are usually characterized by mutations in the CTNNB1 gene. This can be an S45F mutation or T41A or something like that. And on the other hand, as I said at the beginning, we have these desmoids which are FAP associated. And in the study with nirogacestat, there was actually patients from both groups, and we just presented at ASCO, which is a big oncology meeting a couple of weeks ago, which we actually just presented a sub-analysis looking at these both groups, and the bottom line was more or less that the response and the efficacy and activity of the drug is more or less the same in both groups.
Yeah, I'd like to echo that as well. So not just for nirogacestat, but even with sorafenib.
Yeah.
When we didn't publish it, but we did sort of take a look at it, and it didn't seem to make any difference whether you had FAP or not. But I think it's not so much mutations, but I think it's important to remember that patients with FAP invariably have had a colectomy and complete loss of their bowel. And they were already having issues with gastrointestinal issues. So they may have a colostomy bag or not. So in there, they may be having bowel movements of even up to 10 bowel movements a day. So drugs like nirogacestat or sorafenib can, on top of that, have side effects related to diarrhea. So in someone with FAP who's already had a big surgery, these drugs may cause even more gastrointestinal issues. So it's not so much whether the drug works, but whether the drug, if there are side effects that may be excessive. So that's something to consider when thinking about these drugs in patients with FAP.
Thank you so much. We had a couple of questions that are related to some of the language surrounding desmoid tumors. In particular, the language pertaining to whether desmoid tumors qualify as a sarcoma or not, and as to whether they are benign or malignant, and as to what defines a progressive desmoid tumor and not. Could each of you spend some time discussing that and the significance of that language?
Sure, I'm happy to jump on it. I think this is a question that comes up all the time, and I think it's something that the Desmoid Tumor Research Foundation has really tried to grapple with. The first thing I would say is that it is so the definition of what is benign versus malignant is a technical definition, okay? So in oncology, malignant just means whether a tumor leaves where it originally starts and spreads elsewhere or travels elsewhere. So from that definitional perspective, desmoid tumors are not malignant. So they are, from that perspective, it's not malignant. But to say that they're benign also implies that they don't have that they are benign and they're really not causing any problems. And that's not the intent of that technical medical definitions. That's something people need to keep in mind. Also, the WHO, the World Health Organization, they also do pathology review, and they look at desmoid tumors, and they say that they're not sort of the high-grade sarcomas that travel and metastasize, but they're known as intermediate tumors. In other words, they are neither indolent nor are they aggressive. They're sort of intermediate. And as everybody knows here, that these tumors can spread to local organs, nerves, and soft tissue, and cause significant problems for patients who are struggling with this.
And maybe let me add a few words about what we call progressing desmoid tumors. The thing is that we know that the biology of desmoid tumors can be very different. And we also know that a couple of patients can just have a desmoid, which more or less doesn't grow, is stable. We even see in regressions this is reported in the literature in up to 20%, which is maybe quite high, but anyway. So this is actually also the reason why we always advocate for this active surveillance as the first diagnosis, because what you really want to find out at the beginning, does this patient belong to the group with a rather slow growing or not growing, smoldering, or however you would like to call this desmoid tumor, or is it a really aggressively growing, progressing desmoid tumor, causing pain, functional deficits, and so on. That's actually the idea of this active surveillance at the very beginning. And this is also very important when we talk about clinical trials, because when you take part in a clinical trial, you usually have to belong to the second group. So we have to make sure that the desmoid tumor is growing at the start of the clinical trial. And this is measured by radiologists. This is a certain kind of measurement, which we do not have to go into detail here, but we really have to make sure that it is a growing desmoid tumor. And that's also why I emphasize that in the label of nirogacestat, that it's only approved for progressing, that means growing desmoid tumors. Hope that clarifies a bit.
Thank you. I have another series of questions. I'm sort of combining some questions into one. There's a few questions about location-specific treatment decisions. So are there specific either differences in response to medications or differences to treatment approaches that arise due to the location of the primary tumor? Whether in this particular instance, we have questions about mesenteric desmoids, GI. Are there specific decisions that you would make in one direction or another, or treatment decisions, response rates that you would expect that are specific to the location of the tumor?
Mrinal, do you want to take this?
Yeah, sure. So location is very important. So, I mean, I think the decision, Dr. Casper talked about, that one option is to sort of take a wait and watch approach or a active surveillance approach, is to see, well, how does this desmoid tumor really behave at the time of initial diagnosis? But when you are thinking about whether you do active surveillance or systemic therapy, some of the ways I think about whether someone should be treated or not, and which modality to use to treat, really depends on a couple of things. One is the size of the tumor, and where is this located? Is it in a bad location? Is it in a dangerous location? If it were to grow, will it cause serious problems? The second is it growing? And the third thing that I usually think a lot about is, are patients having symptoms or not? And this could be pain, it could be loss of sleep, it could be loss of range of motion, and things like that. So you really have to look at the overall, all the different sort of aspects of this disease. And it's not just the location alone. Location is one of the sort of factors, but it's not all of it. But if you were to just focus on location itself, there are some locations that are, that I think is more concerning. For example, some people will have a desmoid tumor in the neck or in the head and neck area, or along the spine, or deep in the mesentery where the intestinal tract and the bowels are. These tumors are definitely, they're closer to some very critical structures, nerves, blood vessels. So I think they are a little bit I consider them as a higher risk desmoid tumors that needs to be watched more closely, or maybe potentially even treated sooner, and so on and so forth. The desmoid tumors that are in the abdominal wall, which is very superficial, those generally tend to behave a little less problematically. So I think those, when I see those, then I think those are areas where we can certainly think about a wait and watch approach, or sort of I tend to downgrade them as not so dangerous, so to speak. So location does play a role, but it's not just location, it's the size, what else is next to it, is it growing, is it symptomatic? A whole host of other sort of thought processes goes into it. Bern, how do you think about location?
Yeah, I mean, I totally agree, of course. And that's actually also the reason why we developed different treatment recommendations and algorithms for the different locations in our consensus paper. So we have 4 or 5 different algorithms there that are actually influenced by the location, and it definitely makes a difference if you have a desmoid tumor at the head and neck region, or at the extremity, or whatever. And so this is definitely important. And what I always think is interesting to see in this disease in general is, I mean, we are talking about a local disease, and patients always think, oh, it's easy to take this out and we have to treat this locally. But what we see over the last 10, 15 years, that there is actually a shift from local therapies, from surgery, to more and more systemic therapies. And we now have the first systemic approved therapy on the table. And so it is a bit of a weird, idea to treat a local disease with a systemic treatment, but that's actually the development over the last 10, 15 years.
Do you have suggestions for patients who are trying to partner with their care team as far as making these decisions are concerned, how they could help facilitate those conversations with their providers point them towards these new consensus recommendations? Because it seems, based on the questions that we're receiving, that some of the patients are having trouble navigating this dynamic with their providers. Do you have a suggestion for how to potentially encourage them to address that resource or get that resource to their care teams?
I think the publication that came out today is a global publication. It's from US, Europe, Asia, and this is really sort of a consensus building publication. And so I think this is a good starting point where basically experts from around the globe are saying that this is a complex disease that really requires, a group to get together and think about each individual patient and then decide next best steps. And I think this consensus guideline is a good place for patients to initiate a conversation with their physicians.
That's great.
And of course, I mean, yeah, and of course, I mean, organizations like you and the DTRF, of course, are essential and can help in spreading the word, spreading these publications, and what we already did over the last couple of years, of course. But this can really help. I know it's still it's still difficult to reach everybody, but I think we made a big step forward, and yeah. Maybe Lynn, you can also add something to that, but from your perspective. But I think that is a good way to go forward.
I think in the chat there are a couple of questions about pregnancy and also about local therapy such as cryoablation or TACE. Maybe we can start with the pregnancy questions and then talk about cryoablation.
Sure.
Yeah. All right. So I think people want to know, what do you do about abdominal wall desmoid tumors that form after pregnancy? Bern, you want to share your perspective on how you approach these?
I mean, abdominal, these classic rectus abdominis, abdominal wall desmoid tumors are usually ones with the best prognosis, actually, and so it is maybe one of the last locations where we still think of surgery, or where surgery still has a place. And but the overall treatment recommendations are the same. What we usually do at the beginning is, when there is no growth, active surveillance, there is still a place for surgery, but alternatively, we also go for systemic therapies.
Yeah. My own approach has been that, these tumors that are associated with pregnancy, especially if it is superficial in the abdominal wall, or even if it's sort of deeper in the mesentery, is that these are the ones that probably have the highest likelihood of a spontaneous regression. As patients move further away from their pregnancy, there may be changes in their blood cytokines and other things that, for reasons we don't fully understand, these tumors can regress on their own without too much of therapy. I have many, many, many patients. And in fact, many of the patients, even in some of the prospective studies, they all had sort of these superficial wall desmoids that get better on their own. But in this situation where, say, it's not getting better and it's growing, it's symptomatic, as Dr. Kasper said, this is one of these rare situations where surgery can be considered. But at our institution and even my own practice, we try to avoid surgery even for those patients, because you can end up having a mesh placed and the mesh could migrate and could cause complications from that. And that's probably another place, if the tumor is not too big, you can certainly think about cryoablation, because if it's small, these are areas where cryoablation could be a very nice way of freezing the tumor. As far as, there was another question about, can a desmoid tumor grow during pregnancy? And the answer is absolutely yes. It can grow. It doesn't have to grow, but it can grow. And we've seen patients who've had a desmoid tumor completely treated, say, with some drug X. They get pregnant, and during pregnancy, there are new desmoid tumors that can grow. But the good news is, as long as everything is fine, you can deliver the baby, and then some point after that, you can initiate some kind of a therapy to go after these desmoid tumors. Or sometimes they can regress on their own as the time moves away from pregnancy.
Regarding the cryoablation, is there any, it looks like there's actually a couple of questions about that. Is there a limit in the number of cryoablation procedures that a patient can have? That was one question. And then there was also some questions about determining the side effect profile relative to the pain from the actual tumor, and when to make the decision to try cryoablation.
Yeah. So in terms of local therapy, which means, we're not considering surgery. The 3 local therapies is when you're not taking a drug. The 3 local therapies that we've talked about is this cryoablation, which means freezing the tumor. Or the second option is delivering chemotherapy just to the tumor alone. In other words, finding the blood vessel that feeds this tumor and then snaking a catheter right next to the blood vessel and delivering a high dose of chemotherapy just to the desmoid tumor itself. That's second option, which is known as transarterial chemoembolization. And the last approach is something known as HIFU, or high-frequency ultrasound. It's important to note that among all of these 3 options, the first option, the cryoablation, is the one that's been most studied, and so we have more data on it. And yet, there's not as much data as some of the other studies we've done in desmoid tumors. I think the biggest takeaway that I would give is that all of these 3 techniques are extremely highly specialized. And it has to be done by people who know what they're doing, because a lot of these techniques have actually been approved in other forms of cancers or other non-cancers, and they are limited to very different locations. So freezing a desmoid tumor, which is, say, sitting in a muscle right next to a nerve or a blood vessel or near the bowels, it cannot be done by just anyone. I mean, the people who do this, they're known as interventional radiologists, and there are people who sort of spent a long time getting really acquainted with the pros and cons of it. So making sure that whoever you pick, you have to say, have you done this before? How many times have you done this before? What are your, complications, risks, and such, is very key before people start thinking about cryoablation or transarterial chemoembolization or HIFU. So that's sort of the big takeaway, I would say. These things are not benign. There can be complications. There can be even permanent complications of any one of these procedures if you accidentally hit a nerve or something else.
That's very helpful. Thank you. Okay, let's see. There's one other question I wanted to ask that was related. I have lost it. I apologize. Here we go. Can you speak to biomarker testing if a patient has not had biomarker testing or genetic testing of any kind, or if they have not been recommended to have any sort of genomic or biomarker testing done by their physician? Should they have that done?
Bernd, why don't you take it?
Yeah. I mean, it's not actually a biomarker testing, but what we do is what really makes sense and what we really advocate for is doing this mutational testing, because that can help you if you find one of these, what we call CTNNB1 mutations, you can actually make sure that it's really a desmoid tumor, that it's really a sporadic desmoid tumor. And if you find this not, then it can be FAP associated. So what we really advocate for is doing these mutational analysis. In Europe, we do this quite frequently. I know that it's in the US not done so frequently, on it everywhere, but that's usually something we are advocating for.
Yeah, I echo what Dr. Kasper is saying. There's a couple of things that this testing of the tumor is important. First and foremost, these desmoid tumors, as we know, the vast majority of them have these beta-catenin mutation or CTNBB1. And a sub percent, I would say maybe about 10%, 10 to 15%, will have FAP, right? So when a patient is newly diagnosed with a desmoid tumor, you don't know whether it's from FAP mutation or this gene called APC, or whether it's coming from beta-catenin. So why does that matter? What matters is that if a person happens to have a APC mutation, they are at a 100% risk of developing colon cancer, right? So a newly diagnosed patient with desmoid tumor, we would say, you also need to go get a colonoscopy done. Make sure that you don't have polyps in your colon and you don't have something called APC or APC gene mutation or something known as familial adenomatous polyposis. So if you want to avoid a colonoscopy, one thing you can do is get a genetic testing of the tumor. And if the desmoid tumor shows that it's all beta-catenin mutated, then the likelihood that this is FAP or APC really comes down, and you could potentially avoid colonoscopy. But then it's a bit controversial on what to do or what is the implication on the type of mutations found on beta-catenin gene. So there are some groups that say that if you have certain type of beta-catenin mutation, then your desmoid is more aggressive. And if you have another type of mutation, it's less aggressive, or it's more responsive to drugs and so on and so forth. That has not been universally accepted. It's a bit controversial. Some institutions believe in it, other institutions refute it. So in my practice, I will get the test only to decide whether the person needs a colonoscopy or not, or whether that has implications if they have FAP, what else needs to be done, but not so much to sort of tell me about prognosis or how to treat the patients themselves.
That was very helpful. Thank you. Unfortunately, at this time, we do have to wrap up. So let's see here. I just wanted to say thank you to Dr. Gounder and Dr. Casper, Lynn, and Chad for taking the time to be with us today and for sharing your experiences and your expertise respectively. We, of course, appreciate all that you do for the sarcoma community and especially for the desmoid community. Thank you to everyone who logged in today to be a part of the discussion, for all of the questions that you asked. They were really wonderful and opened up the floor for great discussion, continued conversation. Thank you to SpringWorks for the sponsorship of this event and to DTRF for partnering with us on this. It was wonderful to have you share in this event with us. And as a reminder, today's session was recorded. A link will be posted to SFA's website and emailed out to all participants and everyone who registered in the next day or two, as well as posted online at curesarcoma.org. And at the request of all attendees, we will also be sure to send out a link to that consensus paper in addition to the webinar recording. That now concludes our discussion for this afternoon. Thank you to all who participated.